Hello everyone, I'm Xiao from Central South University Xiangya Hospital. It's my great pleasure and honor to have the opportunity to present our team's paper in KJR. Today I'm going to talk about machine learning-based prediction of COVID-19 severity and progression to critical illnesses using CT imaging and clinical data. Coronavirus disease 2019, or called COVID-19, is a respiratory disease which could cause multi-organ sequelae and disease. Since early intervention has been shown to reduce mortality in COVID-19 patients, it is important to give early prognosis of COVID-19 patients. Clinical data, including symptoms of fever, cough, and dyspnea, as well as laboratory findings, have all been useful for the diagnosis and prognostic predictions of COVID-19. Medical imaging, specifically chest CT, is a more specific modality for the diagnosis of COVID-19, and it also has the potential to aid in predicting the severity of COVID-19. Artificial intelligence can recognize features and patterns that are not easily discernible to the human eye, and it has been used to improve the diagnostic and prognostic accuracy of chest CT for COVID-19. In this study, a machine learning pipeline was developed to predict COVID-19 disease severity and the risk of progression to critical illnesses within specific time intervals using chest CT and clinical data. As shown in the Figure 1, a total of 981 patients with COVID-19 confirmed by RT-PCR and chest CT imaging suggestive of pneumonia were retrospectively identified based on data from 9 hospitals and open source data from a previously published paper. These data for the cohort were randomly divided into training, validation, and testing sets with a 7:1:2 split ratio to build the severity and progression prediction models. The clinical information was retrospectively collected. The patient's conditions were determined to be critical or severe if they reached any of the following endpoints: ICU admission, mechanical ventilation, or death. If not, their conditions were not critical or non-severe. The patient's data, including age, sex, white blood cell count, lymphocyte count, comorbidity status, and the history of exposure to the COVID-19 epicenter and or another patient with COVID-19 were collected. An illustration of our workflow of machine learning is provided in Figure 2. First, the lung tissues and the abnormalities caused by COVID-19 were automatically segmented on CT images using a deep learning model based on a deep convolutional neural network. Second, radiomics features were extracted from CT, and a machine learning pipeline utilizing both image-based and clinical variables were used to predict a patient's COVID-19 severity and progression to critical illness at the time of the CT scan. Chest CT scans were assessed using a scoring system adopted for convalescent patients after severe acute respiratory syndrome, as introduced by Chang et al. The computation of severity scores are shown as follows. All CT scans included in the study were divided in 2 parts. Each half was assessed by 2 independent, experienced radiologists in consensus. For severity prediction, the machine learning models were built using only radiomics features, only clinical variables, a combination of radiomics features and clinical variables, or a combination of visual CT severity scores and clinical variables. Feature selection and classifier optimization methods were used to build the models. In addition to the manually optimized machine learning pipelines and automatic machine learning algorithm, tree-based pipeline optimization tool TPOT was used. TPOT automatically outputs the most optimized pipeline after being trained and validated. For progression prediction, two time-to-event models were built on radiomics features and clinical variables represented by risk scores. We selected to test our model using 3, 5, and 7 time points. The prediction based on the clinical variables combined with CT radiomics is the sum of the risk scores obtained from the clinical databases prediction and the CT radiomic feature-based prediction by a ratio of 0.52 with 0.48. For the severity prediction, the following performance metrics were calculated in statistics analysis: accuracy, sensitivity, specificity, PPV, MPV, and the area under the receiver operating characteristic curve. The C-index and the time-dependent ROC-AUC was calculated for progression prediction. The results of our work are as follows. Of the 981 patients with RT-PCR confirmed COVID-19 and chest CT, 274 developed critical illnesses. The median age of patients who progressed to critical illness was higher than those who did not. The clinical characteristics of COVID-19 patients across those with critical and non-critical illnesses are shown in this table. As we can see, the fever, white blood cell count, lymphocyte count, and these comorbidities shows a significant difference between critical and non-critical patient cohort. The chi-square feature selection method facilitated the highest ROC-AUC score of our severity prediction model when used in tandem with KNN and the boosting classifier of the test set. We can see the model based on radiomics features combined with clinical features shows better performance than the model based on visual CT severity score combined with clinical features. The combination of CT radiomics-based and clinical-based predictions achieved the highest C-index. This demonstrated success in assigning risk score consistent with the progression outcomes of patients. As shown in Figure 3, the combination of CT radiomics and the clinical variables allowed the progression prediction model to achieve time-dependent ROC-AUC of 0.897, 0.933 and 0.927 for predicting progression risk at 3, 5, and 7 days, respectively. The results obtained with the visual CT severity score are shown in Supplementary Figure 6. We can see the progression prediction model based on the combination of chest CT and the clinical variables performs better. In this study, we developed a ML model to predict COVID-19 severity and the progression to critical illness using chest CT and the clinical variables with good accuracy. This technology shows potential for informing prognostic decision-making for COVID-19 patients, which may improve patient outcomes and resources allocation. Furthermore, this study demonstrates the ability of chest CT data to marginally increase the utility of clinical information for developing severity predictions. It also shows that a model based on the combination of chest CT and the clinical variables can facilitate a similar performance to that based on the combination of visual severity scores and the clinical variables. Second, we build time to critical event prediction models for assessing the prognosis of COVID-19 patients. Other similar studies didn't give a time-to-event model or gave models based on imaging from admission and a follow-up image on day 4 of a patient's hospital stay. The models in our study only used one image at the beginning of a patient's disease course to develop severity predictions, which could make rapid prognostications. This study has several limitations. First, it was a retrospective study with patient selection bias. Further, the current study defined critical outcomes as mechanical ventilation, admission to the ICU, and death, whereas other studies may have different definitions. It is also worth noting that this study did not include patients without chest CT abnormalities since they did not develop severe disease. The different treatment histories of the patients may have caused bias since only outcomes were used. Laboratory results which are associated with adverse outcomes in patients with COVID-19 were not available for a significant portion of our patient cohort. Additionally, the current study did not include an external validation set. In conclusion, a machine learning model based on radiomics features obtained from chest CT and clinical variable predicted COVID-19 severity and progression to critical events with good accuracy. The model based on the combination of chest CT data and the clinical variables also show higher performance than the model based on only clinical variables and a similar performance to the model based on the combination of the visual CT severity scores and the clinical variables. Further research and development are needed to determine the practical role machine learning can play in COVID-19 severity predictions in the clinical setting. Thank you for watching.